Okay, great. Let me see if I can do this. Okay, I'm in New York. I'm a plastic surgeon. I'm not a dermatologist. Only on my good days, people think that I'm a dermatologist. Yeah. And I'm oculofacial, craniofacial background. So this is a eye case, although it brings all specialties together. I just thought it would be interesting. I'm interested in shape changes with aging and shape changes with surgery. I can't, let me see. Oh, here we go. I don't have many disclosures. I try to keep them under wrap. Let me see, gosh, sorry about that. Okay, so I thought this was an interesting case. It's a 28-year-old lady who, young lady presented 5 months after bilateral canthoplasties. It was performed via the upper eyelid incision access, and she has some related scarring, dehiscences, secondary healing, and her chief complaints were a change of shape of her upper eyelids. She said she doesn't recognize herself anymore, and she also had scarring in the surgical side. So let me see if I can. All right, so pertinent surgical history, as I said, canthoplasties. Her incisions had opened post-op. We don't know why. And she had a scar revision afterwards in October. These are actual timelines. And the incisions opened again. She said each time they looked well healed, then sutures were removed at between 5 and 7 days, and then spontaneously each time they opened. And then they healed by secondary intention. Apparently, she didn't get any instructions. So it's a combination of a difficult patient and some contextual information. We suspected perhaps nutritionally deficiencies and also unnecessary surgery perhaps, and also a complication after surgery. So here is how she presented on her initial consultation. So I'm going to show you close-ups. Attractive lady, let's see. I'm sorry, can you go next? Probably best. Right, so there's not a pointer here, but really the issue, it doesn't seem like a big deal issue, but if you look at her, and I'm going to show her pre-pre photos, her issue was that she said she doesn't look like herself. Her eye shape has changed, and also she had gone to 5 doctors and they couldn't offer her anything. And the scarring. Can you go next? So if you look beforehand, this is her pre-canthoplasty. Question still remains why she needed a canthoplasty, which I think she probably didn't. Obviously, she didn't. but the surgeon chose the upper eyelid for an access incision, which is a very common. I do my canthoplasties and canthopexes from the upper eyelid, but I probably, in her, she would be the one person I wouldn't do that in. I'm going to stop here, and I'm going to see if, Brian, I know we discussed this out there, but I'd love to get your input, and also the other panelists or anybody who wants to comment on this. This is her pre-canthoplasty.
Yeah, I mean, these are really tough cases. One of the, I think, takeaways, when patients tell you they don't look right, or they look different or whatever, and we're just meeting them for the first time, I think it's super helpful to really understand what it is they don't like, because some of the things that we might intuitively think need to be changed, they're actually okay with. And she's got complex eyelid anatomy. Her lid crease is obviously different. Her position of her lower lids relative to her globes is a little bit interesting. She's got a relatively short horizontal palpebral fissure. It's just not entirely clear what she's seeing, aside from the obvious. She's got this scar in her upper lid. Like, you kind of want to know, what all are you seeing? And sometimes when there's a bunch of things that aren't right, if you can fix at least one of them, you're done. And then they stop seeing the rest so much. So that's what I'd try to understand a little bit more about what the...
Yeah, I think it's interesting you say that, because really the bulk of the problem solving here for me was to talk to her. I mean, we had to stop our whole operations, you know, and just kind of sit with her, get her photos, and really try to have her pinpoint what she sees, what I see, what was done, the before, the after, to try to figure out what is it that, how is she perceiving this, the problem, so be able to offer her something. Anyone else? Tom? Janine? Anybody?
Just that case.
So
Yeah.
I actually have a patient, you were saying she had the surgery, I know she had the surgery elsewhere out of the country?
Yes.
Yeah, so I had a patient who had also wanting to get this foxy eye or whatever motivated her, years before went to Turkey and had some kind of foxy eye type surgery, and came to me actually a couple of years later, had gone bounced from office to office with a wound chronically opening in her. The excess was in her temples, in her hairline, and the wound kept breaking down. So I'm wondering if the same. So ultimately, I went in and fished whatever sutures were in there. So I'm wondering if that was the same issue here. Is that there was a chronic infection that was just creating this chronic.
Right. So yeah, so we discussed, oh, sorry.
And then what I would comment is, A, she didn't need it to begin with, so
Right.
there's always that, just the reality check.
Right.
And showing the patients and saying, what is it, how much? Do you know that surgery's not perfect? You could have this complication, that complication. But B, if you're gonna do what you did and fish it out, or what you're thinking about doing for this patient, it's really important to have an adverse events from an outside practice, like literal form that they sign and that you scan into your electronic medical record that says, I went here on this date at this time with this doctor and I had this procedure done and this is an adverse reaction from that doctor. You don't want to be swept up with like a wide sweep litigation later when you're trying to help the person. So it's not even good enough for you to take photos when they first walk in the office because they could, quite frankly, unfortunately people lie. They could lie. So make sure you have them sign an adverse events from an outside practice form before you touch them. Then I may not touch them anyway because I'm that kind of a gal, but at least you have that sign to begin with. That's really important. So, because you could be swept up in litigation for whatever later, okay?
That's a huge super, and I'm definitely taking that as a note. Also, I want to announce that they are extending this session until noon and then doing lunch. So if we want, we can kind of stay and maybe have some discussions. I can give you the exciting conclusion to my talk.
Oh, that's perfect. So Janine, that's a really good idea. Of course, we don't have such a form, and but we need to do that
immediately.
But that's really, if there's one take-home message from this, I think that's that. So after really evaluating this, and as we were discussing, this would be the one person I would not approach from the upper eyelid incision for the surgeons in the room for either acanthopicsy or acantoplasty, even though that's my preferred route. To keep the lower eyelid incision shorter. Usually that's what I do because her, not only is her crease is high, but also mainly because her crease is short longitudinally. So to reach her lower lateral ligament or retinaculum from the upper eyelid, you really have to extend her incision. So to extend her incision, the way they did it in a straight line, it just distorts the shape of her eye. So if this person had come to me, first of all, I wouldn't do acantoplasty on them or acanthopicsy, but also I would have a full disclosure and discussion with them that their upper eyelid was going to look a little differently if we did this, and they would extend their crease to some extent, and that scar may be visible. But in any case, we were where we were. And can you go to the next slide, please? And so with much trepidation, I just wanted to show you her, if I go next again, sorry. So this is her pre and post. So if you see, to drive home what I just said, what happened, the scar visually distorted the end point of her upper eyelid fold crease. Okay, so the reason, and this really was because we stopped everything, we started talking, I started talking to her at length. She visually does not recognize herself because now her crease sort of doesn't stop, but goes in a different direction, more horizontally. So next slide, please. So what we decided to do is to sort of do a multimodality and try to address the scar, the pigmentation aspect of the scar, the texture of the scar, and the fold. And I did counsel her that she hopefully will be better. There's no guarantee, but her crease, her fold is just is never going to be the same length anymore. So she has to be prepared that she'll look more like herself, but never exactly the same. So she got pulse dye laser treatments to the scar erythema. I used the high G prime filler for her bilateral upper eyelids. I used the scar, part of that horizontal scar, and actually filled over it to create a fold because the scar had flattened it, which is what you can't probably experience just from the 2D photos. 2 sessions of that to create an actual fold that's lateral to her own natural fold. And we did some microneedling with PRP at the parameters you see there. We did several sessions of that. So those are the dates, so you can see the timelines. She had come in November, now we're in March, and these are the procedures. And let's go to the next slide. Okay, so I'm gonna, can you go to the next slide, which is probably a close-up? Yes. So here you see her results. She doesn't have makeup on. I didn't believe it. After I saw the photo, I ran in there and I was like, can you take your makeup off? And she actually has no makeup. She really responded well. She's also younger. She responded well to the laser treatment. This is a low technologies that we were able to use to create that. But if, I'm gonna show her pre and post, and you'll see her fold is not exactly the same. The shape has changed to some extent, but at least it resembles herself. So I think by combining attacking the scar texture, the scar pigmentation, and the shape of her upper eyelid fold/crease, we were able to get something. I didn't actually expect these results, so I was actually shocked. I was truly shocked. I was like, I couldn't believe it, like my jaw dropped. I was like, oh my God. But I think, again, it's helping someone who's pretty distraught, and hopefully they learned a lesson, we don't know. Can you go to the next slide? So this is her, again, before and after, no makeup on the right side.
That's beautiful.
It's also her, her
Amazing
response, her PRP must have been really good because, as we know, not all PRPs are. No exosomes. I have some things to say about exosomes. Next slide. And that one, and then every little bit helps. I think the high G prime filler was really key in extending that crease and creating a fold. And then next slide, please. Sorry, go next. There's an extra slide in here. Oh, sorry, too many slides. Next. So here's pre-canthoplasties, pre-anything, presentation in the middle, and then post. And if you look on top and the bottom, if I could show it in higher mag, the crease is a little bit longer, or at least looks a little bit longer, or the fold rather, not the crease. But she looks more like herself. She doesn't look distorted.
She's lucky.
Questions? Can you go to the next slide? I think that's it. I think actually that's the last.